And then football too. Now, how many concussions have you?
None.
None.
I got
None diagnosed.
Yeah.
That's good.
Wow. Now, so bring your knees together. So, we're, well, the question came up. This may be a good place to do it. See, if I do a standing forward bending test, and the test is a lot more positive than the sitting forward bending test, usually that patient will have an ipsilateral fullness in the lumbar area on that side compared to the other side. But to me, that usually says there's something in the legs. Okay, and usually it's below the knee. So if I have a patient that has a real positive standing forward bending, fullness on one side, it gets better when they sit down. That says to me the legs are a player. So then I'm going to check fibula heads, distal fibula, tibial rotations, foot and ankle. Then if I find stuff in there, I'll treat it out. And most of the time, you stand them back up and recheck the standing forward bending test is gone, that fullness is gone. You think, that's pretty neat, because you might have got sucked into treating that lumbar area because of all that fullness in it, okay? So that's, now if the sitting forward bending test is more dramatic than the standing, then that says to me it's either lumbar area, sacrum, or pelvis. So then what I would do is after he came back up from the sitting forward bending test, I'm going to rescreen the lumbar area and rescreen over the sacroiliac. And if it's more lumbar, I'm going to find the most restricted, treat it. If it's more over the sacroiliac joint, then that's when I'm going to switch paradigms and say, okay, got to rule out up shears, down shears, pubes, sacrum, and I'm going to go through that way. So see how we're doing that? So let's see here. Now, just when I just get a hold of his feet and ankles, there is so much more tension around that right ankle, and it feels hard as a rock. So not good. We're gonna have some stuff. The bad news is it may not change. It may make me look like a fool. So then I like to check talus. So I got my thumbs on the talus, and you want to keep the feet parallel with the floor. See, and I can get some glide there, but look, there is no glide there at all. Okay? Then get the ankles at 90 degrees, and he externally rotates. But look at, I can't even get to neutral with tibial rotation. So that thing is externally rotated like everything. And let's see if they corrected the distal fibulas and stuff. Did they treat anything?
We did like.
We did inversion tibial or tibial. Tibia was rotated
Internal
externally.
rotation.
Yeah,
Well, I'm saying it's externally rotated. See, I can externally rotate them equally.
Yes, that's what I mean.
But then when I see, most of the schools teach you to check these individually. And I think Mitchell had it right. Then you got to remember in your mind what you found. Whereas I like to do everything bilaterally, because then I've got a great comparison. And then the other neat thing is he can be looking down and see the changes. Mm-hmm. And then after I get through, if he sees the changes, then go, hey, he made a change in that. So that is externally rotated, and both externally rotate well. But then when I keep those ankles in slowly, and look at this one will go past neutral. This one can't even get close to neutral. Okay, but the distal fibula you got going. Okay? So let's see if the proximal fibula.
And there's a navicular issue too that we corrected.
Okay, so the fibula heads are working pretty good. So you made some changes there. So now it looks like it's localizing more down in that foot and ankle. So then, how I like to examine the foot, and I had never thought about it. Somebody in one of the rooms said, when you have the foot on your leg, are you introducing ground reactive forces? I had never thought about that, but that may be true. So this is how Mitchell taught us to examine the foot. And think about, most of the time when we have a foot problem, what happens? The arches fall, right? So that means the bones in the arches won't glide cephalad. Okay? So what I'm going to use is my thumb as a probe. I've got my fingers over the front of the foot and the palm of my hand right over the toes. See, and then I can just palpate along the medial arch. And that's pretty good. There's a little restriction right there, but it's not that bad. So medial, see, and I'm pushing up as I bring the hand over. So you checking, will that glide cephalad? Can you glide an arch in there? Then I get laterally, and that's pretty good. Then I can check the two transverse arches. Ooh, right there. Don't like that. You don't either, do you? And then usually right in front of the calcaneus, Mitchell called that show parts area. Remember, that's where talus, calcaneus, navicular, and cuboid all come together. Okay? And that area enables the foot to invert, evert, abduct, adduct. And when people lose that, boy, it usually affects that plantar fascia like everything. And I find that dysfunction really commonly in people with plantar fasciitis. But his is more a little anterior to that, right there. So the treatment is muscle energy. You do the same thing. So I'm gonna flex over that thumb, adduct, invert, and then compress. And think about every one of those movements is building an arch, right? Now you try to pull your toes apart and dorsiflex. And a term I used from you guys, you were using the windlass phenomenon in the plantar fascia to build that arch. And stop. And again. But what's restricted more than his foot is that talus. So let's just see if this changes. And again. And stop. We got a little more movement in there. Yeah, that's moving some better. But I don't think it changed. It didn't change the talus. Okay. So talus, you really don't have any muscles attached to it, right, to do a good muscle energy technique. So I always do that functionally. So I like to have the heel on my knee, and I'm going to palpate that talus medially and laterally. Then get a hold of the front of the foot, and I want to, so this is, if it's functional, is it direct or indirect? Indirect. So what are we doing? Taking the dude where it wants to go and fiddle and diddle, right? So let's see. It will dorsiflex a little bit, but it plantar flexes better. It will adduct. Boy, it doesn't want to abduct. It'll invert. Doesn't want to pronate like that. So I've got those three movements in there. Now what I'm going to be doing is putting compression in from the front of the foot with my right hand, from the lower leg with my left hand, and I'm putting another vector up through my knee. Because remember, that's a triplanar joint. And as soon as I got those three vectors in there, boy, that thing is starting to move. But can you feel anything happening? What does it feel like to you?
Feels like it's gliding.
See, and I'm not doing this, he's not actively doing it, we're just on the ride, we're on the bus with his body unwinding this thing. Ooh, look at the dorsiflexion that just came in. It was pretty neat. See, and then I can, that's about all he's going to give me. But then I can put a counterforce on there and say, now try to push your foot down into my hand and add a muscle energy effort to it. And stop and stretch those posterior fascias.
Or you could do a little high velocity.
And again. And stop. If I do that, I ruin my reputation.
So Ed,
Yeah.
in that position, you think you're getting talus, calcaneus, talus, tibia, both at the same time?
Yeah.
But sometimes do you ever have to do talus, calcaneus by itself, or treat
Yep.
the calcaneus by itself?
Yep. Yep. So now what I want to see is how has that made a change? Then if it hasn't, then I'm gonna rescreen that foot and ankle to see what else is going on in there. And then lots of times you'll find it's calcaneus. So let's see. We get the ankles at 90 degrees, external rotation. And look at, he's going past, can you see that? He's passing past neutral now. Now there's some tightness in the other one. Now let's see, let's check Talus. So there we are there, and look at that. He actually has more movement in that one now than he has in this one. Did that feel different?
Yeah.
Now, yeah, and see, and when people say that, think about it, what are they basically saying? They've got movement they haven't had before, and that's a good sign.
No frame of reference for this.
Yeah.
Chronic pain sprains.
So just walk on that now, walk back and forth a couple times, see if it